I'm David Holmes from Rochester, Minnesota, an associate editor of JACC Intervention, and I'm going to be talking today with Dr. Soren Brenner about the incredibly controversial subject of stent selection during ST segment elevation myocardial infarction. Soren, you have written about that. It seems like the issues are exceedingly controversial, and they relate to several different specific concerns. One relates to that issue of stent thrombosis. Is it higher with drug-eluting stents in the setting of ST segment elevation myocardial infarction? One relates to the need for dual antiplatelet therapy in that setting and the ability to talk with the patient ahead of time to see if they are going to be compliant with it. One relates to the issue of how important is it to use drug-eluting stents, given that target lesion revascularization may be less in those patients with ST segment elevation myocardial infarction. And then finally, how do those things impact your practice and the data that you are publishing now? How does that impact your practice?
These are very important questions, and I think they all essentially hone down our skills as well as our doubts about what to do with patients with ST segment elevation myocardial infarction. For me, the most difficult part is really to ascertain how compliant the patient is going to be. And so in the rush to perform balloon angioplasty within the guideline-mandated intervals, I think we have very limited time to take a very good history from the patient to know whether he or she will need soon any non-cardiac surgery that might require the interruption of dual antiplatelet therapy or potentially all antiplatelet therapy, as well as how compliant they are in general with medical therapy. So I think that because of those issues, many of us are reluctant to implant drug-eluting stents in the setting of ST segment elevation myocardial infarction.
So how then do you approach the patient in terms of trying to decide that?
So I think that in general, what I do and recommend that we do is that patients who are known to the system where you practice, patients that have been either your patients or patients in your group, and that there is a track record of how they approach medical care in general, I think a simple 30-second interview, when did the pain start and whether are you going to need any surgery in the near future would suffice. And there I would feel very comfortable to apply the evidence-based medicine, if you would, in order to decide whether a drug-eluting stent or a bare metal stent is recommended. For patients in whom language barriers, patients who are not known to the system, patients who have never been to a cardiac care before, there I'm much more reluctant, and I usually prefer to use a bare metal stent and take the chances that restenosis, if it occurs, and as you said, it seems to occur not very frequently with the current stents, we'll treat it when we get to it.
One of the other issues then is the safety issue of stent thrombosis. Despite dual antiplatelet therapy, some people have said that stent thrombosis is going to be increased in that prothrombotic milieu.
So the issue of stent thrombosis is very important. Intuitively, one would think that with a high burden of thrombus in the infarct-related artery, there is a higher likelihood of stent thrombosis after stent implantation. I think that the majority of the data points to the fact now that there isn't a higher rate of stent thrombosis with drug-eluting stents over bare metal stents, but both of them have higher rates than in the setting of elective angioplasty. So I think we need to be cognizant of that fact.
So in your day-to-day experience in your institution, what is the frequency with which you use drug-eluting stents versus bare metal stents in that setting?
In general, I would say that of all patients with ST segment elevation and myocardial infarction, about 3/4 will get a drug-eluting stent, and 1/4 of the patients will get a bare metal stent.
Thank you very much. This has been incredibly interesting. It's very controversial.
Absolutely.
You have shed some light on it, and I look forward to making sure that people have the opportunity to review the article in depth and continue our discussion. Thank you
very much.